Hi, my name is Nadia James, and I will be narrating this brief presentation and part one of a four-part series on evidence-based pain management in the Periop area. In the part one of this series, I'm going to be talking briefly about some statistics on pain, chronic pain, and how that ties into the importance of evidence-based pain management in the periop area. To give you a little background, I did a little while ago informally query some folks, some of my coworkers, on topics of interest and issues in the Periop area that was near and dear to them. And I got some great suggestions. Some evolved around more like flow, patient flow issues, and other practices. And one of the topics that is personally near and dear to my heart is pain management. So we're going to talk briefly about that today, just introduce you to the topic. Next time, part two, I will go into more detail in about the art of assessing pain, because we see a lot of different pain scales available to us in Cerner that we can document on. But honestly, aside from the numeric scale and some of the other ones, I think it's a good idea to receive a refresher on how to complete those. One of the things that I really hope maybe we can do one day is install like little bulletin boards in all of our pre-op patient rooms, where we can put like a laminated faces, the Wong-Baker faces pain scale that we can then readily use on our younger patient population or the older that have some cognitive deficits. In part three, I will do a review of pain pharmacotherapy, because there's a lot of different modalities out there to treat perioperative pain. And then in part four, I want to go into more detail on how important patient education is and managing the expectations, because evidence and research has shown that the better we educate our patients from the get-go, the better they have a better pain experience post-operatively. I want to begin by first going over what we mean by evidence-based nursing practice. We hear that term all the time, but sometimes I think it's confusing to us or to some folks on like what exactly that means. And the definition that I'm going to use is sort of like a combination of three main facets that together make up evidence-based nursing practice. First, we use the best available research evidence, meaning we need to find peer-reviewed journals and articles that pertain to the topic that we're interested in, and try to find research that has been conducted or published, let's say, in the last about 5 years. Sometimes, in school and whatnot, we've been told we can go back as far as 10 years, but what we have to keep in mind is that for a research study to get published, years can pass. So you can collect data at this time, you interpret it, you analyze it, you convert the information into a manuscript, then you have to send it to journals, it gets peer reviewed, it gets rejected, you have to revise it before it's finally accepted, and then there can still be a lag until it's actually published. And so sometimes some of the research articles that we read are already, 5 or more years after the fact that the study was done. But and we don't always have access to journals, but Ascension does give us an opportunity to utilize their access to databases like CINAHL and PubMed, as well as like some of our coworkers who are members of professional nursing organizations that also publish peer-reviewed articles in their own publication, and gives us access to those articles. The second key piece is clinical expertise. I'm not sure if you ever heard of a nurse theorist by the name of Patricia Benner, but she developed the theory of novice to expert. So, like, what trajectory do new nurses, are on as they graduate, start their first nursing job, and then, after, some time, become more proficient, become, and then at a later point become experts. So definitely there's time involved, and I think that expertise is something valuable that also contributes to evidence-based nursing practice. Patient values and preferences. Again, evidence and research has shown that if we, or when we involve, not if, but when we involve patients in their care and decision making about their care, including pain management, their needs are much better met, and they have a much better pain uh, management experience than if we do not, if we assume and choose not to include them. Some of the barriers that we experience to practicing evidence-based nursing. There are two main types. We have organizational or institutional barriers, and those I would consider outside of our control, like lack of time, limited resources, insufficient support, resistance to change from the leadership, and inadequate training and mentorship. So I do not want to spend that much time on factors or barriers that we cannot control. The type of barriers that I do want to focus on are what I call individual barriers, because those are based on us and come from within us, and those we do control. And one of the main ones is for evidence-based nursing is a knowledge and skills deficit. We just don't in our nurses training. I started with an associate's degree in nursing, never was taught or exposed even to nursing research, except through the textbooks. But nobody, none of my faculty and my professors ever pointed out and spoke about evidence-based research. Some of us too, like we have maybe preconceived, not so positive beliefs and attitudes towards evidence-based practice. Our work experience, in what kind of setting were we socialized into the nursing profession, and then our more senior nurses, myself included, sometimes tend to say, well, I've always done it this way and it's worked, and so I'm going to continue to do it this way. Also, I may not actually have the research or evidence to back up my practice. And then we have younger, newer nurses who are just so overwhelmed and trying to absorb and learn and manage their time that they're just, evidence-based practice is the last thing on their mind. And just again, individual motivation. So today's focus is on the individual barrier that I call knowledge deficit of evidence-based pain management of the adult periop patient. I preface this presentation also with pointing out that individual knowledge and knowledge deficits exist on a continuum. So for some of us, this is going to be a refresher of this type of information, while for others, this might be quite new information. Did you know that September is Pain Awareness Month? I did not know that until I started researching for this presentation. And the ribbon color for pain awareness is blue, like navy blue. And so I have little pins that I was passing out doing my in-person presentation at the education meeting. But I have lots of little pins left over, so please find me or Jessica after you have listened to this presentation, and we'll be happy to provide you with a pin to help us raise pain awareness. Why is evidence-based periop pain management important? Research, again, has shown that post-operative pain is one of the most common concerns for surgical patients. And the American Nurses Association's Code of Ethics, which was recently updated and you might be familiar with, has a section that deeply emphasizes nurses' ethical responsibility to relieve pain and suffering. I created a handout about the key points of this Code of Ethics section. And again, please find me or Jessica, and we'll be happy to provide you with that handout. Here are some statistics on why evidence-based pain management in the Periop area is also so important. The CDC's National Health Interview Survey, with data from the end of 2023, showed that over 30% of adults aged 18 to 64 reported chronic pain. And they have two definitions: chronic pain and pain that restricts life or work activities. And either one of those was shown to be the most common reason adults seek medical care, and even including in the emergency room setting. Their data also showed that chronic pain has a higher incidence in women. More women than men suffer from chronic pain. And it also increases with age, which again, when we look at our patient population, we can see that, and we want to keep that in mind when we interact and look at, gender, age, sex, that those also fall under the social determinants of health, and pain management is definitely something that is affected by social determinants of health. The Agency for Healthcare Research and Quality, or AHRQ, is a well-known quality agency that hospitals and health systems use quite a bit. And their numbers from 2020 to 2021 showed that 12.7 million, or 6.4 adults aged 18 to 64 filled at least one opioid prescription in that year. And during the same period, 1.8%, or 3.6 million people, filled 4 or more. Just think about that: 4 or more opioid prescriptions or refills. And so we see that in our pre-op patients in the medication reconciliation list, when we get to know our patient and complete that list, or in PAT, when our coworkers in PAT start gathering that information, how many of our patients do take opioid medications. The data also showed that women were more likely to fill at least one or have 4 or more opioid prescriptions, which does make sense when you look in the numbers above, that chronic pain seems to be more prevalent in women than in men. Another statistic that I included because I found it interesting was that adults with lower incomes were more likely than those with higher incomes to have any use and frequent use of opioids. And let's think about the patient population here in our area, in Panama City and surrounding areas. And we do know that they are from a lower socioeconomic status, which again is a social determinant of health. And I'm not sure the science behind this, and I'm sure there is a lot of research, but we want to be cognizant of the fact that those folks do tend to have a higher or more frequent use of opioids. I don't want to bore you with the detailed pathophysiology and physiology of pain. I think we can think back to our training and our education on all the nociceptors and whatnot, and what's happening in the central nervous system in regards to pain. I want to keep it simple. We have 3 types of pain. We have acute pain, we have chronic pain, and we have acute on chronic pain. And I think the main focus, if we think about our average Periop patient, is the acute on chronic pain situation. It's defined as a temporary increase in a person who already has chronic pain. So, and usually it's in an area different than what is usually causing the chronic pain. So if a patient has chronic back pain or osteoarthritic pain, and all of a sudden they need abdominal surgery or mastectomy, then that would be the new acute pain. And those type of patients can be very challenging to manage pain-wise in the periop area. And the periop pain management starts with our co-workers in pre-admission testing. That group of folks has worked with anesthesia and Dr. Isaac, the chief of anesthesia, to develop a list of medications that they either tell patients not to take the day of surgery or sometime before, and a list of medications that are okay to take the day of surgery. And on that list, there's a nice comprehensive list of most commonly prescribed opioids that per anesthesia patients are okay to take the day of surgery. When the patient gets to us, especially the outpatient patient, then we, in pre-op, as part of our admission assessment, we should do a detailed pain assessment. Like in Cerner, those fields are long and lengthy, and they go into details of the quality of pain. Is it constant or intermittent? Are there secondary pain sites? And if you feel like you're not able to truly document thoroughly enough, then you can always right-click on that field and add a comment to go into more detail. It's also important to make sure that we ask the patient what is an acceptable, tolerable, manageable pain level for them. Because if they have chronic pain and they're already coming in with a pain level of 3 or 4, but that might be manageable to them. And so we don't want to assume that we need to get to 0 because that might not even be possible. So especially the PACU staff would appreciate it, or does appreciate it, when we tell them, or when they can see that the patient's post-op, acute pain management goal is not 0, but maybe something more, higher than that, because the patient has that underlying chronic pain. Our anesthesiologists have different order sets with different number of medications and type of medications. But let's be an advocate for our patients and contact the anesthesiologist if we feel that our patient has chronic pain to come in with, or they came from the floor and it's been a while since they received a PI medication, or despite taking a medication at home, they're still having a large amount of discomfort, that we contact them and request an order for PRN pain medication. And we should use our clinical judgment, but I think we should not the fact that they may have not signed their consent yet as automatically preclude us to give a pain medication. If a patient has been taking pain, opioids, for example, they are not going to be, severely affected by it and are so going to be so sedated that we cannot get them to sign consents. And being, sleepy but arousable is not the same thing as being cognitively impaired and unable to truly, understand an informed consent. So we want to make sure that we differentiate between those two and not use that as a reason not to treat the patient's pain. So don't be reluctant to give the pain medication. And if you're not sure, consult with one of your colleagues or the anesthesiologist. Here's a screenshot of the list of opioid medications that I mentioned in a previous slide that PAT uses when they meet with the patient, with the outpatient, and to advise them to, medication that they're okay to take the day of surgery. The only medication that I do not see on there is tramadol. It is officially considered an opioid, but it's a very milder medication. Maybe that's why it's not on there. But I would also consider that, an opioid, but still patients are okay to take them the day of surgery. And this was approved by Dr. Isaac, according to Tracy, who I met with before when I was preparing this presentation, and wanted us to, and she has a copy. If anybody wants a copy of the okay to take medications, please just check in with Tracy or one of the other PAT nurses. There are quite a bit of resources available if you are interested in pain and pain management. There are international and national organizations that focus on pain. There is the International Association for the Study of Pain, or IF, which was founded in 1973. And when I was looking at their website, and I saw that there is a international Congress on neuropathic pain in this month in Berlin, Germany. And the U.S. Pain Foundation has a little bit more of a focus on, the consumer and patients rather than healthcare professionals, while the American Pain Society does focus, on pain for medical professionals and actually publishes the Journal of Pain, a peer-reviewed research journal. Other resources available to you are in My Learning, for example. When I did a quick search, just pain management or pain, in the search bar, I got over, and I limited it to like web-based, self-directed modules. I got over 70 results. And any one of us who had to take the 75 Aspen modules during our orientation might remember that there are several pain or modules on pain management, including for the pediatric patient. I also quickly wanted to mention that if you have an interest in learning more about evidence-based nursing practice, that Ascension actually offers workshops. Those are like, again, virtual on evidence-based practice. And when I was looking at it, there was actually session 4. I don't know what the total number of sessions were, but I believe they are repeated, and that was offered for this month.